All right. And with that, once again, welcome. For this webinar session, we are going to be focusing on opioid use disorder in pregnancy. And this webinar is being presented by Dr. Carolyn Lefebvre. Just a few words to introduce Dr. Lefebvre. She's a member of the medical staff at Maine Dartmouth Family Practice, where she provides full spectrum family medicine services to patients, including obstetrics and pediatrics. She is also a faculty member at the Maine Dartmouth Family Medicine Residency Program, and also serves as the Director of Recruitment at that program. So with that said, please join me in welcoming Dr. Lefebvre. And Dr. Lefebvre, the floor is all yours.
Awesome. I am sharing can I share my screen?
Yes, you should be able to.
Trying to get it. Can everyone see that now? All right, so first, before we start, could people put in the chat how familiar they are with opioid use disorder treatment? I just want to know like how many people prescribe buprenorphine already. So okay, so it looks like a mix. So none, some, very familiar, great. Don't prescribe, familiar, not prescribe, great. Okay. So really a mix between people. So this is a presentation that I gave at the Maine Academy of Family Physicians with one of my colleagues, Kelly Harmon, who's our addiction medicine specialist here. She's a family doctor who's our addiction medicine coordinator. So this is really just an overview for people interested in starting to prescribe. Just as we don't have any financial disclosures, I do use both generic and name brand medications here. And then also of note, there are times where we'll say mother or women, but we do acknowledge that there are non-binary folks who can carry babies, and so it really just applies to anybody with a uterus. So the biggest part, and this is more for those of you not already prescribing, but people dealing with opiate use disorder come from all walks of life, all education levels, all socioeconomic backgrounds, and many come with a significant trauma history. So a big part of what we do is making sure we're practicing trauma-informed care and not underestimating the number of people that are encounter this on a daily basis. And this quote at the bottom here, "Be kind, for everyone you meet is fighting a hard battle," is actually this big quote that's on the main stairway of the employee entrance of our hospital when you walk in. And so just a nice reminder for those things. So the biggest thing to address is stigma and making sure we're using appropriate language and moving away from moral judgments. And I do, kind of cringe when I see some of these words in, notes from the emergency room of like clean, dirty, and do really try and teach residents not to use these words when they're talking about patients. They're more judgment words, and so not putting that in, but using more like patient-centered language. And so like we've moved away from substance abuse to opiate use disorder, or drug-affected baby to substance-exposed infant. These words are nice. The clean and dirty are the biggest ones to get away from, like a clean drug screen versus a dirty drug screen. So we use appropriate and not appropriate is what we use here. So how prevalent is opiate use disorder in pregnancy? So I practice in Maine, which is one of the highest rates of opiate use disorder in the country. So we see a lot of this, and our Maine Dartmouth family practice was one of the very first places to prescribe Suboxone or buprenorphine for pregnant women. And so two of our former faculty wrote the paper that is really the basis for it. So as will not be a surprise to anyone, the rates of opiate use disorder have risen rapidly in Maine and nationally over the last decade. And so in 2021, there were 636 overdose deaths in Maine, which was a 23% increase. And most of what we're seeing is fentanyl. We really don't see as much heroin anywhere. So almost everything is laced with fentanyl. A large majority of overdoses were non-fatal, and naloxone distribution was likely thought to help from that. We do dispense it right from our clinic to basically anyone that asks for it. So our some national and local data that drives our practice. So we have seen a huge increase, like greater than 100% from 2010 to 2017. And then the hospital cost for a newborn with neonatal abstinence syndrome is more than 8 times the cost of a otherwise other newborn, and has a significantly increased length of stay. So this is a huge cost to the healthcare system and a huge amount of the time we spend on our OB and PEDS floor. Here in Maine, over the last 5 years, between 1 in 12 to 1 in 15 of all births in Maine are substance exposed infants. So it's about 8 to 10% of, or sorry, about 6 to 8% of what we see. It's slightly higher at our hospital based on the region we're in. So this is the rate of NAS per 1,000 newborns. So Maine's NAS rate was 27 newborns per 1,000, which is significantly higher than the national rate of 6.8 per 1,000. You guys can all see where your states fall there, how much of a problem this is. This is a graph from the Maine Department of Health in terms of substance exposed infants. As you can see, this graph, we should be changing the words from drug affected to substance exposed infants born throughout Maine. This does look like a downward trend towards 2017, but I think some of it is that we're doing a better job treating it. So this is all based on discharge data. And so what we may not be capturing here are the babies that don't require pharmacologic treatment. And I'll talk about the two options, methadone versus Suboxone. And there tends to be a lower need for pharmacologic treatment with either methadone or morphine in babies on Suboxone. So this may represent that we're doing a better job stabilizing mothers with opiate agonist therapy during pregnancy. So what we see in Maine, it's certainly a polysubstance use disorder. So marijuana, legal in Maine, a huge percentage of our population uses marijuana both before, during, and after pregnancy. In women that are also on opiate use treatment, they're on marijuana. It is linked with more severe NAS and longer infant hospital stays. Marijuana is also in case, I don't think I'm telling people anything they don't know, but marijuana is fat absorbed in the fat. So in breast milk, it's actually concentrated. And so babies get a higher amount of it. So we do try and do a lot of education about that, but really should be focused a lot on decreasing marijuana use, particularly during breastfeeding and pregnancy. We also see stimulant use, both prescribed and unprescribed. So we do have women who have ADHD. It's a common co-occurring disorder with substance use. And then also patients using cocaine, which is much more difficult to treat and can cause more severe problems for babies. SSRIs may be helpful in treatment for those. More rarely, we see benzodiazepine use. That can be a much longer withdrawal period for a baby, on the order of months. We don't see as much alcohol use, but it's probably a lot more prevalent than we realize. And then nicotine, also hugely problematic, and really reducing the amount during pregnancy is key. So what treatments are available? So MOUD, the previous terminology was MAT or OAT. So MOUD now stands for Medication for Opiate Use Disorders, a new terminology to use. And that's the use of a medication to counteract opiate withdrawal symptoms. So there's really 3 types that are available: methadone, buprenorphine, naloxone, or Suboxone, which is dual therapy, or buprenorphine alone, which is Subutex or monotherapy. There's also Sublocade, which is a long-acting injectable form of buprenorphine, which is not currently approved in pregnancy. So dual and monotherapy are now both acceptable for use in pregnancy, and our practice is to keep women on their Suboxone rather than switch them to the mono product. The reason to prescribe the dual therapy, it helps prevent abuse of it with the naloxone in it. And what that is, if you were to inject the medication, the naloxone can cause a much more severe withdrawal symptoms than if it's not injected. The naloxone is not orally active, so you don't get withdrawal symptoms if they're using it sublingually. Great, and people stop me at any time if you guys have questions. As lots of us that work with patients with opiate use disorder know, medications certainly support recovery, but the real work is in behavioral health and lifestyle changes. So methadone or buprenorphine are both the standard of care for treating pregnant women with opiate use disorder. Methadone, we cannot prescribe from our clinics. It has to be federally dispensed from certain federally licensed clinics, and care can be more fragmented that way. They only do methadone there. We tend to start women on buprenorphine and only transfer them to methadone if they have a higher level of care or need daily checks or are struggling more recovery in that way. They also, if they are on a much higher amount of methadone, so you can't really switch from methadone to buprenorphine until you're about like 40 to 60 milligrams of methadone. So if you're on a much higher amount, they can go into withdrawal if you switch them to the buprenorphine. So for this talk, I'm primarily talking about buprenorphine treatment. It's what we do in our family practice and what many other family practice providers do as well. So buprenorphine, it comes in tablets or films. It's dissolved sublingually. You do have to have an X waiver for it. It's a prescription you pick up. You don't have to go to a specific clinic, and is associated with less severe neonatal abstinence syndrome. And like I said, there are the 3 forms: the dual therapy, monotherapy, and the long. So anytime we start a new medication during pregnancy, we have to weigh the risks and benefits. And there are many benefits to using opiate agonist treatment in pregnancy for opiate use disorder. The reductions in maternal morbidity and mortality, decrease obstetric complications, reduced illicit substance use, reduction in illegal behavior, and also less fluctuation of maternal drug levels throughout the day. It's also been shown to improve engagement and prenatal care, allowing providers to help the patient prepare for birth and encouraging stability. All of those things which can help increase the likelihood of the patient keeping custody of their of their children. We do not advocate for withdrawal during pregnancy because that increases the risk of relapse without any real benefit to the fetus or mother. So those are the benefits. When we talk about the risks, the biggest risk with buprenorphine we've seen is an increased risk for SGA, or the baby being small for gestational age. So it is recommended that you do growth scans every 4 weeks, starting at 24 weeks. There is a risk for NOWS, or neonatal opiate withdrawal syndrome, which is the withdrawal syndrome that's specific to opiate. Neonatal abstinence syndrome can occur from any medication taken by the mother during pregnancy. This is an expected and treatable condition that follows prenatal exposure to opiate agonists. It can be treated with non-pharmacologic measures or pharmacologic measures. So morphine or methadone is what we use in our hospital. They're all different protocols for that based on where you practice. The incidence and duration of neonatal abstinence syndrome doesn't differ based on the maternal dose of methadone. However, trying to minimize that dose before delivery can cause more problems for the mom, which could present more problems during delivery. And there are some studies that find lower rates of NAS when you do split dosing of methadone, and that's really specifically for methadone. So the big question, which to use in pregnancy. So methadone does have more medication interactions. It can interact with antiretroviral agents. It can prolong QTC intervals. And all of those should really be considered before starting any medications. I did have a patient on methadone who had really low magnesium and potassium, and while she was not pregnant, actually had a cardiac arrest related to that while she was on it from a QTC prolongation. Methadone does have to be dosed daily, typically at a clinic. There are some clinics that allow for take homes that you can do a week at a time or more at a time, and tend to have more frequent adjustments during pregnancy. Buprenorphine has advantages where it can be dispensed from a primary care clinic. It can be dispensed by the same provider providing OB care. There are some trials that show that there are less severe neonatal abstinence syndrome, but it has not been studied for as long. I think the first studies are probably 20 to 20 plus years ago, but don't have great long-term data on infants and children in buprenorphine yet. So for treatment recommendations for opiate use disorder in pregnancy, so the goal is to optimize mental health care in the prenatal period. It can be a time that patients are most engaged in recovery. And so a great time to identify their support network, especially peer recovery, so group programs, individual counseling, and then identifying safe family members and friends. We will take in our clinic, we'll take any pregnant patient who wishes to engage in medication assisted treatment. We will also take their partners or anyone supporting them as well, because we know that treating the whole family is really the best way to take care of the patient. The prenatal period, it's also a time to identify any social needs that they have. Here in Maine, we call it a plan of safe care, which is their discharge plan for the baby, and thinking about what referrals they need in place. So we have public health nursing, case management, WIC, Maine Families, and Cradle Me's are two other services that are kind of wraparound care for maternal child health. So this is what the plan of safe care looks like here in Maine. So this is a standard form that our social worker here fills out before the baby is born. It's their current strengths, like assistance and goals, where the baby is born, who their primary care provider is, do they have substance use exposure, like any withdrawal symptoms. And then all substance exposed infants and their caregivers are eligible for early intervention programs, which is supports basic needs for up to 36 months after that. This is another kind of checklist resource of is this patient providing all of these services, and then who are they contacting? So we know I picked family medicine for the idea of integrated care for all families. And so when I had my first baby, I had my first baby in med school between my first and second year of med school. And I remember like going for all of these OB visits. And then I had this baby and I went for my follow-up and they're like, okay, we'll see you next time. Like you have another one. And I just felt like, what do you mean? Like you're the doctor that I've established care with. And then this lovely specialty of family medicine presented itself, and I'm like, this is the way we should be caring for all patients. And I so wished I had had that with my first baby, to have that care. So I think the integration of opiate use disorder and prenatal care is the perfect place to do this in family medicine. We know that there have been studies that the integration of those two care can help reduce the risk of preterm delivery, placental abruption, intrauterine fetal demise. We've done QI projects that the integrated care increases the number of prenatal visits. It can help decrease the relapse rate. And women that enter during their first trimester are more likely to be in medication-assisted treatment 1 year postpartum. And it's really we do a lot of group visits. They've been on hold for the last 2 years, but we're planning to restart them soon. But they have been amazing for both treating patients, training residents, getting our medical team involved, and just really lots of benefits to doing that. So our group visits, these are some of the topics that we have talked about. So for first-time parents, what to expect in the hospital, what neonatal abstinence syndrome looks like, what the reporting laws are, postpartum issues, talking about birth control, like understanding how buprenorphine works. It's just so much more time to talk about those things in a longer study than in a quick 20-minute visit. And this is basically all this wraparound care is basically what the implicit program is. So some social barriers or issues that we face are certainly transportation, homelessness, limited financial resources, relationships with partners or families, and childcare. But developing this community of people is really the most helpful thing that we've found for this. So within our interprofessional team, we have family medicine, we have clinical social work, we have nursing, inpatient and outpatient. We work with our OB groups, MFM, pediatric hospitalists, counselors, physical therapy, lactation consultants. So we have lots of people that are involved with the care of these patients. Here in Maine, we have a Maine Mom program. So it stands for Maine Maternal Opiate Model. And so it's a 5-year project that's led by Maine Care, which is our state-funded Medicaid. And it's a $5 million grant with dedicated staff positions to help develop a system of care for pregnant women with opiate use disorder. So it's a QI project. It is a great project, but it is really focused on helping create a pregnancy home to help coordinate care for women with opiate use disorder. And it's available for any woman with pregnancy. So even if they decide to terminate the pregnancy or have a miscarriage, they still qualify for a year to help with this wraparound care and social support. Our family medicine practice. So here at Maine Dartmouth, we have 2 residency continuity clinics, 1 faculty only clinic. We're a hub for this program for Maine General, but we do partner with, we have a private OB group that delivers at our hospital. We have a hospital-based OB group. We have a midwife group. We have other outpatient providers that send their patients to us. And we're kind of the home to help coordinate that. So even if we're not doing all of their OB care, like if they're a more high-risk patient or complicated that they're seeing an OB, we'll still co-manage with visits and come up with a plan so that at the time of delivery, everyone's on the same page and they've gotten great wraparound care that way. So for the medical management of opiate use disorder, it's really routine prenatal care, plus starting them on medication as soon as they're able, getting them a naloxone prescription, following up on the prescription drug monitoring program, which methadone is not show up there. So if a patient is on methadone, it will pop up in any state PMP. If not available in-house, we should be referring them for substance use treatment, referring other people in the home for treatment. We do tox screens at every visit to help not only demonstrate stability, but watch for any other exposures for the baby. We do recommend we call it a level 2 anatomy scan. So that's a detailed anatomy scan to make sure that's overread by MFM provider. And then at 24 weeks, you start the Q4 week growth scans. And we also consider in the 3rd trimester repeating HIV, hepatitis C, gonorrhea, chlamydia, and syphilis screening based on their risk factors. So if they were actively using at the beginning of the pregnancy, we traditionally repeat those. And Hep C screening is now universally recommended for all women in pregnancy. So how does the medical management change over the course of the pregnancy based on metabolism? And so both methadone and buprenorphine like you end up increasing the dose over the course of pregnancy. So methadone split dosing might be helpful and actually is associated with some decreased severity of NAS afterwards. And then buprenorphine, the plasma concentration decreases over the course of pregnancy. And so we tend to increase it in the 2nd trimester if they start to have more withdrawal symptoms, but there's not a dose dependent relationship with the severity of NAS. So some medical considerations, the one I should probably have bolded and in red is that constipation is very common, both in pregnancy and in patients with opiate use disorder. And so to treat that very seriously, the higher amount of progesterone during pregnancy decreases transit time and worsens the constipation that comes with opioids. So really, we talk about this. We should talk about it more and more often than we do. But increasing water intake, adding fiber, using Miralax if needed, milk and magnesia, lactulose are all safe during pregnancy, and so really treating that aggressively can help. We found that IV access and getting labs can be triggering for patients, especially if they have a history of IV drug use, and scarring of the veins can be common. We, with all of our POCUS training for residents, we have done ultrasound guided lab draws in the office or thought about pre-arranging that. And at the time of delivery, thinking about a vascular team or anesthesia consult to place an IV. Then cholestasis of pregnancy can be, there can be a higher likelihood if they have chronic liver disease, like if they have hepatitis C or a history of cholestasis. And that, you can get itching of the palms and soles. It interferes with sleep, and typically that presents in the 3rd trimester. To diagnose that, you have to get bile acids And then there is an increased risk of stillbirth, so the delivery is recommended around 37 weeks, but just knowing that that can be more common if they have underlying liver disease related to their opiate use disorder. It's also important to remember that common pregnancy symptoms can feel like withdrawal. So sometimes it can be hard to kind of parse those things out. So nausea, vomiting, cramping, restless legs, like those are all like you feel crummy when you're in the early stages of pregnancy and in opiate withdrawal. So some of the other mental health diagnoses, it's important to address those as well. There are significantly higher rates of depression, anxiety, PTSD in opiate use disorder. SSRIs work really well. Whatever SSRI the patient is on is probably the best one for them. If you're starting something new, we typically start with sertraline. That is also a dose that might need to be increased in the third trimester. And it's always a risk benefit in terms of using the lowest effective dose. SSRIs can contribute to withdrawal for the baby. SSRI withdrawn babies tends to cause more like jitteriness or shakiness, and we see that in like babies exposed to SSRIs that mothers are not on opiate use disorder, but can contribute to that, as can nicotine withdrawal as well. We think about referring to psychiatry if needed. Counseling is crucial. And then also thinking about barriers to care. So whether it's childcare for their other children, fear of DHS or CPS involvement, and transportation, how can we address those before delivery? Trauma is a risk factor for substance use, and substance use is a risk factor for trauma. So it's very common, as high as 100% or 99% of women with substance use disorder report a history of physical or sexual abuse. We know that patients that have been abused as children have higher rates of alcohol use disorders, are more likely to use illegal substances. So it is important to think about those as related to delivery. The whole idea of, like, especially in a woman with a sexual abuse history, very important to talk about that and consider that around the time of delivery. In terms of preparing for delivery, for a patient on buprenorphine or methadone, you want to continue their regular dosing of those during hospitalization. Think about any non-pharmacologic supports. So we use nitrous oxide, epidurals, intrathecals. Those are all safe. It's safe to use those if they have fentanyl and anything like that in the epidural. There's not an interaction. For patients that go on to C-section, that you need to use opiates after delivery, you would want to we traditionally keep them on their scheduled dose of buprenorphine or methadone, and anticipate they're going to need about 1.5 times the usual dosing. You also want to make sure you avoid Nubain or Stadol, as you can precipitate withdrawal if you give them those while they're on Suboxone. I also was recently at a conference where they talked about for acute pain management, you splitting up the dose of buprenorphine. So it's like every 4 hours, every 6 hours can be better for pain control. We have not traditionally done it. We've always kind of operated on the give about 1.5 times the usual dosing. So that may be something we move to doing in the future to get better pain control in those patients that it's needed. It's also been important for us to prepare parents for an extended hospital stay for neonatal abstinence syndrome observation. So here at Maine General, our protocol is to watch them for 5 24-hour periods. The risk of withdrawal is highest at about day 3. So we watch them for that full 5 days. Other hospitals around the state have different protocols. Um, Other parts of the countries do. So it's all kind of based on what the protocol is where you live. We also have a substance exposed infant reporting law. So we're like mandated to report it. And that's where that plan of safe care that I showed before comes in. Important to educate parents that buprenorphine or methadone, it's compatible with breastfeeding. The only reason we would tell them not to breastfeed if they're hepatitis C positive and they have breakdown of the nipples would be a time we would wait for that to heal before they put a baby to breast. Postpartum, the buprenorphine or methadone dose stays about the same initially. Often by like the 6 to 12 week postpartum visit is when you could think about starting to taper, but we typically keep it at, if they were increased during pregnancy, keep it at that higher dose for a while until you reduce it down. This is a great checklist of evidence-based recommendations for caring for pregnant women with opiate use disorder. This is all publicly available on the Main Mom website, and I can send out the PDFs of this, or I'll send to Maha to send to everyone. But this is a great checklist. It has exactly the protocol that you would recommend for initiating buprenorphine. We are doing this in our emergency rooms now. Within the hospital, if there's a pregnant patient coming to the hospital for looking for treatment, if they get admitted, our family medicine service tends to be the ones that are consulted for this. So that's the second page of the checklist. That is the third page. So the other one to highlight here is thinking about a postpartum contraception plan. About 85% of pregnancies in this population of women are unplanned. So this is a time during pregnancy should be when we're thinking about postpartum contraception, if that is something they would like. So in terms of caring for patients in the postpartum period, postpartum support is as important, if not more important than during pregnancy. Babies going through withdrawal can have high cries. They can be very fussy. If anyone has cared for these infants in the hospital, they can be really upset, like really hard to care for, like constantly fussy. Like think about your fussiest baby you could times 100 is what sometimes these babies before they're treated are. And during that time it's important to optimize non-pharmacologic management, so swaddling, dim lights, quiet, rocking, skin to skin can all be helpful with that. We do encourage breastfeeding in stable patients. For this, we make sure we've talked about pain management for mom ahead of time. So postpartum, we're continuing to talk about that. And then making sure we continue our integrated care. The maternal risk for relapse and overdose is highest postpartum. So it's a really critical time to get parents engaged in care. Like I went through before, postpartum pain management, maximize NSAIDs and non-opiate medications, making sure those are scheduled is important. Make sure they stay on the same dose of whatever medication they're on, methadone or buprenorphine. And then it is okay to use the full opioid agonist for post-op pain, but knowing that they're going to have a higher requirement. Even with how long we have been doing this here in our hospital, we still have times where people put them on lower doses because they're on buprenorphine, thinking that that would be better, and they just really have a higher need based on the partial agonist that they're on. This is data that was presented at the Mass General Psychiatric Academy about rates of substance use disorder deaths related to pregnancy. And so this was from a presentation Dr. Jessica Gray gave at that. I can't highlight this enough, but the postpartum period is an important, it's such a risky time for patients with opiate use disorder, both on medication and those not. The rates of relapse are high, interpartner violence and overdose all increase significantly, and the majority of substance use related deaths occur in that first year postpartum. So this is comparing substance use related deaths during pregnancy and postpartum compared to all pregnancy associated deaths. So it's just this huge amount postpartum. This is all based on data in Massachusetts. But in their data, approximately 1 in 5 pregnancy associated deaths were related to substance use. So this is a huge public health, problem. So why would they be more vulnerable in this period? Well, loss of access to special services they could have. There are higher risks of postpartum depression. There's stress of a new baby or stress of separation if there's DHS involved. And there's also the shame and stigma that come along with patients watching their infant experience those symptoms. We certainly have patients in the hospital who are on buprenorphine that don't want their family members to know they're on it. And it's always, I mean, now we haven't had any visitors, but when visitors were more allowable, you know, like making sure nursing staff weren't talking about that in the hospital, and like how do you explain why they're there longer and why they're having more difficulty is always a tricky conversation, but trying to respect patient wishes in that way. So what can we do as family medicine providers? I think this is the crucial time for family medicine providers to be involved. I think, like I said before, the beauty of family medicine is that we care for the whole family, which is just the most natural fit for this care to continue from the prenatal period to the postpartum period. So there's lots of things that we can do. We can support newborn feeding, we can support breastfeeding, we can answer questions about hepatitis C or safe medications and breastfeeding. We can complete the plan of safe care if it hasn't been done prenatally. We can make those referrals for support. We can help with pain control. We can monitor for over medication. We can get them in earlier for a postpartum visit. We really would advocate for that 2-week postpartum visit for all these patients. And then also doing co-visits with well child care for caring for the newborn as well. So this is all part of the fourth trimester project that really falls within this. It's all just good postpartum care, but continuing that. I know a lot of places around the country use this form, but the SWIC is the Survey of Wellbeing of Young Children. It's a developmental screening tool that was developed at Tufts. It's available for free. It has both developmental and behavioral screenings as well as family questions, which I find to be the most valuable pieces of information. I know when I've been to FMEC, I've seen people present the SWIC lots of times, but what is nice at the 2, 4, and 6 month visits, the Epstein postpartum depression screening is built into that. So you have it there. So these are some of the resources that we've used. So the Maine Mom website has tons of information. The PCSS website has lots of information as well. These are just some of the references I use, but I am happy to answer any questions that people have. Thanks. Are there other folks that are doing this wraparound care within their, I know some people are very comfortable prescribing medications, some weren't at all. Anyone doing things differently that work well.
I'm in Connecticut, and I think compared to your program at Maine, I feel like your care is probably more wraparound than ours is. We're a little bit fragmented. We see patients in the community health center, and then the hospital has like their own team of social work and lactation resources and things like that. It's not as it's a little bit more fragmented than what you presented that you guys are doing in Maine, which is awesome.
Yeah, no, I trained at Maine Dartmouth, so this is where I did my family medicine residency. So I kind of like expect this is the way that everyone does it. But we do a month in Nashua, New Hampshire, and I was blown away by how many fewer patients were on Suboxone there compared to here. Like any patients, they were pretty much on methadone, and there were a significantly lower number, which I think like that part of New Hampshire, it's not so much lower an opiate use problem than it is here. I think it's just not being done in the same way that we do. So one of the questions, how do you treat withdrawal symptoms in newborns that were treated with buprenorphine? It depends. So we use the Eat, Sleep, Console protocol, which some people may be familiar with. So instead of using like the Finnegan scoring for NAS, it's really, does the baby eat, sleep for, I think it's either 1.5 or 2 hours, and then console within 5 minutes with like normal things. And if they're doing all of those things, you keep optimizing non-pharmacologic treatment. So it's really based on more like optimizing like swaddling, soothing, sucking, those types of things, and more parent education for it. For babies that need medication, like those things aren't working for it. They're not able to do one of those things. We typically use methadone, and then when you start methadone, you get a capture level, and then you wean. There's typically a weaning course that's set out by pharmacy that tends to take somewhere between I don't know, like 8 to 14 days, based on how quickly you can wean them, and then they're in the hospital for that full period. We've had a handful of patients, and I know our pediatric hospitalists are working on a protocol for like Purine morphine doses. Like, can you get away with just giving 1 dose of morphine to babies that are more on the cusp of like, do you need to start methadone or not? Like if you can treat them 1 or 2 times with them morphine to get them through that immediate withdrawal period. But I don't have like an exact protocol for that. That's really more kind of case-based with our pediatric hospitals group. And I know there was a group, I did my 3rd year of med school up in Bangor, and one of the NICU docs there and one of the outpatient pediatricians were actually doing outpatient methadone treatment for NAS. Like you get a capture dose, and then they're seen in the clinic like every 3 or 4 days and dispense medication. It was a longer weaning period, but those babies were at home for it, and there's like certain criteria for it. I'm not sure they're still doing that program anymore, but that was kind of another model that within the state of Maine, since we unfortunately have a lot of experience with it.
Dr. Radcliffe, did you want to say something?
I would say, number one, we have 2 prenatal systems of care in family medicine that do a lot of MAT and have a lot of patients affected by this disorder. In the community health centers, or FQHC, we have a small subset of folks who work with incarcerated women, and also with the Healthy Beginnings program. They have more of a specialized program on this. But I think that the bottom line is this is something that we all face in some way, shape, or form. And the more we can learn from each other and collaborate, the better we would be. In the implicit network, we're working on the 4th trimester program, and which lends itself very well to a collaboration with care models. So I hope that as we head down the road that you all in Maine will think of perhaps joining this network and bringing some of your expertise and learning from us as well.
Yes, my plan is for Maine Dartmouth to join the implicit network as soon as I'm our recruitment director as well. So as soon as recruitment is over and I can submit our IRB for us to officially join, we will do that. But yes, I have wanted us to join the implicit network for a while, and we're finally at the point of doing it, just a matter of time. So. I would also encourage people, this is not of all the things we do in family medicine. This is something that has such an, like, if you're not prescribing medication or thinking about prescribing buprenorphine, it is a amazingly beneficial drug for patients that it can be helpful for. Like, it is a life-changing medication. And I think of all the things we do, like I will see patients back every, 3 months for their diabetes, and I can never get their, like, chip away at their A1C. In terms of like life-saving medications, this has been one. And I think the experience we have with that and taking care of OB patients, it just flows so beautifully. I don't think these are patients that, I mean, they are higher risk because they're like a social, a lot of times the social stuff that comes along with it is the biggest challenge. But it's something we have a huge amount of experience in. And so I think we can really offer a lot for these patients. So if you're not already doing it, like thinking about doing it, it is like, of all the medications we could prescribe in pregnancy, it's pretty, it is lower risk than lots of them. So.
Thank you. Can I ask, with women now or patients using a lot higher doses of fentanyl, are you seeing women coming in or patients coming in on high doses of fentanyl where our Suboxone is not going to touch it? Are you treating them with fentanyl? Is there concern for withdrawal for the fetus? I wonder if you could talk about that and how you're doing it in Maine.
Yes, no, we are certainly seeing more of that. And so there's some protocols for microdosing, which is like small, like much smaller amounts of buprenorphine. The problem is that, like, you don't want to encourage anybody to be using fentanyl. So we're not like telling people to go out and use it, but the microdosing is to like a much smaller amount that hopefully you get through some of that initial withdrawal. We will hospitalize, like we'll have patients be inpatient to get them through that withdrawal, and like giving them like other supportive medications to get them through that period. In early pregnancy, we definitely do that. But we have been more successful with the microdosing protocols for patients on high doses of fentanyl. I would say most patients we get up to 16 milligrams of buprenorphine. Depending on who you ask, that's kind of like the ceiling amount. Like above that, you don't get a lot of benefit in most patients, but in pregnant patients, we can go up to 24 milligrams. There are fewer of those, but you certainly can increase. And I know different like that's kind of our traditional thought here with the people I work with, that like 16 is kind of the max except in pregnancy. But other groups you talk to, like there are plenty of people that prescribe up like 24 milligrams and above.
If I can talk to you, I have actually prescribed more than that at times for non-pregnant and pregnant patients, and especially with people who have been on fentanyl. And I think there's more data to support that. Looking at the people who are on 16 milligrams and beyond, they're the people who tend to do better. So I think maybe that 16 milligrams may be eroded over time.
Yeah, that's great to hear, and certainly think we're seeing that more. Traditionally we dose it twice a day, like it is a 24-hour acting medication. But sometimes people do better taking it 3 times a day or even four times a day. So the total dose doesn't change, but the frequency changes.
Right. Thank you so much, Carolyn. Any last minute questions? All right. Well, again, once again, thank you so much, Carolyn, for this presentation. Definitely very informative. And I will be, making this recording available and the resources and the slides that are available once they're prepared. And thank you so much again, everyone, for joining us. And you'll be hearing from me in a couple of days with this information. Thank you so much.
Yeah, I'll send you the PDF of the main mom stuff, because it's really like all the checklists you could possibly need, the protocols and everything. So
Perfect.
great. Thank you, everyone.
Thank you. Have a wonderful evening.
Thank you.